Good morning all. So we welcome you on the 16th lecture of our GAN course. So now Professor Kavita Shah will deliver the lecture. We have the title in non-precision cancer, therapeutic surgery, radiotherapy and chemotherapy. Thank you.
So for the past few days we have been discussing precision therapy, right? Now we actually go back to non-precision therapy, which is still used extensively throughout the world. Okay, so the main three ways one can treat cancer without knowing exactly which targets are wrong in that particular cancer are surgical, radiotherapy and chemotherapy. So surgical is very good, especially for skin cancer, right? You can see it easily and then people remove it surgically. If people have prostate cancer, initially prostate cancer is very localized, okay? So surgery is the first option and it is a very effective option also. So something you can remove almost 100%, right? Surgically, you just get rid of it surgically. Okay, radiotherapy, I briefly told you about radiotherapy. So radiotherapy is very localized, right? But localized means it is facing the tumor, but still normal cells are going to get harmed. So we'll discuss that. And chemotherapy is a systemic therapy. All the cells in the body are exposed to chemotherapy. So that's pretty bad, but if the cancer has spread and it is metastatic, one has to give chemotherapy. Okay, so I wanted you guys to know these definitions. So those of you who have come a little bit later today, so we have an exam on Saturday, right? And where I will have questions for you and you have to answer them and then you will get your certificate. So I did not mention anything before because I did not remember about the exam part myself. But as I go along, I will tell you some hinters that remember this, remember that. So these are the, because I give you a lot more details than you are required to remember. So specific things I will tell you that you should remember. So this is one of those things, okay? So curative therapy explains that, it has to be cured. So if you can surgically remove the whole tumor or chemotherapically you remove the whole tumor, that is, if it is curative, then it is the best option. Adjuvant therapy is that chemotherapy destroys cancer cells after surgery or radiation therapy. So even if you remove something surgically, there is always a chance that 0.01% of cancer remains. Then you give chemotherapy, hopefully for a short period of time so that everything dies. Okay. Neoadjuvant therapy is that chemotherapy shrinks a tumor before surgery or radiation therapy. Suppose it is very big tumor, right? So they give chemotherapy for some time, okay, to shrink the tumor because smaller the tumor, easier it is to remove. So that is called neoadjuvant therapy. And palliative therapy is that, it has gone beyond a certain thing and it cannot be removed completely, but you still give the therapy to prolong the life of that person and to improve the quality of life. Okay, so that is palliative therapy. That is the last option. So just to give you some comparison, you guys know immunotherapy very well, okay, versus chemotherapy. So they are both systemic therapy. Immunotherapy and chemotherapy are both systemic, but immunotherapy is turning on the immune system, so the body is fighting. In chemotherapy, we are giving chemicals, okay, to kill cancer cells, but the downside is that when you give these chemicals, it also kills the normal cells. That's why people lose hair and all the other side effects. So this is what it is showing. Traditional treatment has, look at the side effects, tremendous side effects, okay, and post-treatment protection is not that great, okay, but if you give immunotherapy, side effects are a lot less and post-treatment protections are much better. And keep in mind, immunotherapy is extremely recent. So this is a very recent therapy and this is a game changer for cancer patients. Okay, so and targeted therapy, if you know specific targets are upregulated, then you give the drug targeting those and the signal is turned off. So look at this thing. This is giving all the signals to the nucleus, right? Targeted therapy works in such a way that they block the signal. Now, I always keep giving you example of Herceptin. So you may think that these targets have to be expressed at the cell surface. That is not true. It can be anywhere. It can be a nuclear target, cytosolic target, or cell surface target. Okay, so any number of targets. It could be anywhere in the cell, all right? An ideal target is that target which is specifically expressed in cancer cells and absent in normal cells. Second thing is that if it is present in normal cells, so this is present in normal cells also, but in very small amount. In cancer cells, it is overexpressed. So when you give the drug to that, you would ideally you would like that normal cells don't care about this receptor. So even if you inhibit it, nobody cares. So normal cells are not going to care for it, then less side effect. Okay. So here I am comparing chemotherapy, targeted therapy, and immunotherapy. So chemotherapy targets rapidly dividing cell. What is the side effect? Hair loss, intestinal damage, nausea. Can you explain to me why intestine is specifically damaged during chemotherapy? Yes.
Cell lining is constantly changing.
Yeah, because our digestive system is actually churning, right? It is mechanically working. So what happens is that our digestive system keeps replenishing the cell lines very rapidly. So they are rapidly dividing cells which are making the lining of our digestive system. So when you do chemotherapy, the whole thing is affected. That's why the patient feels nausea and intestinal damage, and they will start bleeding because you are stopping the cell division rapidly. So that is one of the major reasons. Okay, hair loss, intestinal damage, and nausea. And then cancer cells very rapidly develop resistance to chemotherapy. So that's the bad news. Okay. Now targeted therapy like Herceptin, so this is much better, but it still leads to a lot of problem. Many cancer drugs damage the liver because liver is a major organ where detoxification is occurring. So when you give the therapy, now body doesn't know what is foreign, what is not foreign. So obviously the drug is foreign, but it's supposed to cure the body, but liver will still try to get rid of that thing. So it can lead to liver damage and all other things. And again, resistance develops after some time. Immunotherapy, somebody told me that, one of you guys told me the other day, immunotherapy, what about autoimmune disease? Because you are turning on the immune system. Yes, it can be a side effect, autoimmune disease. Okay, and this is pretty expensive. That, having said that, it is not freely available. It is available to everyone here because it is becoming a major way of treating cancer. So it's not the availability problem. Because it is a biologic, it is very expensive. And this is not something you can take it at home. The person has to go to the hospital to get it administered. Okay, so this is just showing you different treatment options for lung cancer, which is a very common cancer due to smoking. So the person who smokes get it, and the person who are exposed to smoke, they also get it. And pollution, again, lung cancer. So this is the major people, this is the #1 cancer in the world. Okay, so you can give chemotherapy like cisplatin, paclitaxel, surgery. Surgery is hard in lung cancer because it is, inside and lungs, it is hard compared to prostate cancer or skin cancer. Okay, radiotherapy is a radiation therapy, immunotherapy is given, and depending, there are many kinds of lung cancers. The most famous one is non-cells. Good, thank you. I can never speak that one, right? So you guys know that cancer. So EGFR, EGFR receptor is overexpressed. So you have many targeted therapies for lung cancer, okay? So this is chemotherapy and this is radiation therapy, okay? So radiation therapy is localized treatment that use high energy beams to target the tumor itself, okay? So this is chemotherapy, can have side, so this person is explaining all, you know, when someone goes to the doctor, they have to explain all the positive and the negative things about a therapy, right? So it says that it can have affect system-wide beyond the primary tumor, which is always the case in chemotherapy. It is given usually IV or orally. Goal is to kill cancer cells or at least shrink cancer cells. Okay, side effect includes all of these things and often administered in cycles. Now for radiation, high energy, we will not see these slides obviously, right? Damage cancer cells, tumor shrink, and can kill cancer cells for weeks or months after initial treatment. It can be given from outside, or actually they can insert, they can insert it inside, and then it will kill it. And side effect, mouth sores, throat problems, and fatigue. The most important thing is that in both cases, tumors develop resistance. So if you really clean it up, and if it never comes back, that also happens in large number of cases, but in some cases when it comes back, it is resistant to it, okay? Surgery, obviously the goal is curative, remove all visible tumor, especially in early stages. Like I said, in prostate cancer, you can remove complete tumor at early stage. Sometimes what happens is that the tumor is so big that before you give chemotherapy, it is so big, and chemotherapy will take time to shrink the tumor, and then eventually it will develop resistance. So you have to fight against time. So what they will do, they will remove the vast majority of tumor by surgery, and then they will give whatever tiny bit is left, then they will give chemotherapy. That is what kind of therapy? If you do surgery and then give chemotherapy, what is it called? Adjuvant therapy. Very good. That's when adjuvant therapy is very useful. And similarly, if the tumor is little bit spread out, then they will give what kind of therapy before surgery? Neoadjuvant. Yes. Okay, and palliative you already know. Okay, and you also do diagnostic. So for example, if somebody has breast cancer, they will take out a little bit of tissue and do the biopsy. Okay, I know of a friend, so she developed lip cancer, okay, in the lips, and so it's a skin cancer, right? It is on the lips, so it's skin cancer, and she has been going surgery after surgery after surgery after surgery, like for months. And every time she cannot eat things so it's excruciatingly painful, but at least it can be removed by surgery. She's suffering, but it is removable because it is skin cancer, okay? So limitation, advantages, removal of tumor mass immediately, curative potentially localized disease, that's very good news, and useful for diagnosis and staging. So one time I had an infection, right, some infection in my lip, and that would never heal. So they gave me this drug, several localized things, something, it didn't work. And then they finally did a biopsy, like cut it out, checked it. By the time they figured out what was on, it healed by itself. So I had to just undergo biopsy, but it healed, but the body figured it out, whatever it did, it just healed by itself. But what I'm saying is that even for tumors, they do biopsy. Otherwise, how would you know it is HER2 positive, right? They have to do biopsy there. So biopsy is very common, okay? So surgery is only effective for localized tumor. If it is metastatic, you cannot do surgery, right? And may not eliminate microscopic metastasis. So this is the bad news. So somebody has a tumor in the liver. This is the primary tumor. And then it metastasizes in the lung and other parts of the body. So if you are doing surgery, obviously you cannot go all over the body and start removing it, okay? And risk includes bleeding, infection, okay? So surgery is highly effective for skin cancer, obviously makes sense, it is visible to us. So this is the visible lesion, so they cut it out this. This is step 1, then they will go and remove another layer, and then they will remove another layer. This is called Mohs surgery. Okay, so Mohs surgery is a stepwise layer by layer removal of skin cancer while examining each layer under a microscope in real time until all cancer cells are gone. Look at the success rate, 99% for basal cell carcinoma, 97% for squamous cell carcinoma. That's very good, right? That's really good. Okay, lung cancer surgery is not that easy. First of all, anatomical and technical limitations, because going to the lung is not that easy. And then if it is like this, spread out, you cannot do surgery everywhere. In Seattle, they have developed a new technique called histocrispy or something like that. So they are developing where they can go and clean up different things. But these are not very commonly used. Okay, these are not, but these techniques are coming up where they can come and clean up all of these things. Another problem is tumor biology and heterogeneity. Like there are many different kinds of, in one tumor you have 100 different things which are going wrong. Okay, so that also creates, and lung cancer is diagnosed at a late stage, and that is very hard to win. Any cancer which is diagnosed at a late stage, they don't show symptoms. So there is nothing you can do about it. Okay. Now let's talk about radiation therapy. So there are three kinds of radiation therapy. External beam radiation therapy, as the name suggests, it is giving from outside. Okay, most common delivered by a machine from outside the body. Brachytherapy, radioactive source placed inside or next to the tumor. Okay, and the third is systemic radiation, radioactive isotopes delivered orally or intravenously. So you may have heard of this thing, that many people who have thyroid problems, right, they have to image the thyroid. So they give radioactive material intravenously, or sometimes, intravenously, orally also. Okay, and then your thyroid lights up, because radioactive, they will just go there. It is radioactive iodine, and thyroid tissues take up iodine. So thyroid lights up, and then they do the imaging. Okay, so that is systemic radiation. It's not good for you, but that's what they do. Okay, all right. So what is the mechanism of radiation? When you give radiation, DNA is damaged. Okay, so it leads to cancer cell death. Healthy cells have better repair capacity than cancer cells. So keep in mind, what is chemotherapy? Chemotherapy is given so that the DNA is damaged. So there are two principles at play here. First, cancer cells, they have defective DNA repair system. So normal cells, when they are exposed to chemotherapy or radiation therapy, although in radiation therapy we try to be as accurate as possible, just focusing on the tumor side, but still a lot of normal cells are also affected, right? Because it's microscopic kind of thing. So and you have to get rid of all the cancer cells. So you are using it in a larger area relatively, right? Because you just don't want to kill the inside of the cancer cells, you want to kill outside also. So the radiation is actually outside also, right? Outside of cancer. So that is why it is killing normal cells. But normal cells can repair their DNA much faster than. So chemotherapy does one thing, it damages the DNA, but the principle is that normal cells will repair faster, they will not be affected. Second, cancer cells are dividing faster, normal cells are not dividing that faster. That is why cancer cells preferably die. Okay? So advantage is that if you are giving it from outside, it is non-invasive. When a person, any patient, whether he or she is a cancer patient, any patient, people prefer non-invasive methods. Anything it is invasive, people don't want to do it, right? So it is non-invasive, especially the outside radiation therapy can be precisely targeted, used for local control and palliation. Okay, and limitation often affects surrounding tissues, long-term effects, fibrosis, organ damage. And obviously, if it is metastatic, you cannot expose the whole body to radiation. That's pretty bad. Okay, so this is the external one. You can see it is localized at one place, and in this internal they have put a catheter, and this is the radioactive source, and this is internally doing it. But if cancer has spread to different parts of the lung, you cannot just get it at all the parts, so it's very bad. If it is a primary tumor in one place, you can do it. Chemotherapy uses cytotoxic drugs to kill rapidly dividing cells, which includes both normal and cancer cells. It interferes with mitosis, DNA division, or metabolic process, administered orally, intravenously, or intrathetically. So chemotherapy is used both for primary cancer and metastatic cancer, certainly for metastatic cancer, because it has spread everywhere, so you have to give systemic therapy. Okay, localized tumor they also give when they don't really know the target there. So remember I was telling you that one lady went there, she was not very rich and she did not know much about it, so she had HER2 positive cancer, and the doctor did not even bother to check HER2, which is very easy to check. He directly gave her chemotherapy and she died. And had he diagnosed the disease properly, Herceptin would have saved her life, because her cancer was not spread out or anything, but the doctor didn't even bother. So what this is telling you, if you have a choice of targeted therapy versus chemotherapy, one should go for targeted therapy because it is less toxic also. Okay. So these are some chemotherapeutic agents. So cyclophosphamide, it leads to DNA cross-linking, obviously it leads to cell death. 5-fluorouracil methotrexate. Anyone knows what methotrexate does? This is a very famous drug. Have you guys heard of tetrahydrofolate?
Is it folic acid antagonist?
Exactly, that's what it is. It is not folic acid antagonist, but it works in the folic acid pathway, DHFR pathway. So there is an enzyme called dihydrofolate reductase. So it inhibits that one. Okay. And these are mitotic inhibitors, paclitaxel, vincristine, it blocks mitosis. Mitosis is, what is mitosis? The cells are dividing, right, into two, and the mitotic spindle is formed. So there the microtubules are the, so Leknath, you must have seen the beautiful pictures of mitotic spindles, right? So these are microtubules. So if you inhibit at that stage, mitosis will stop, okay? So these are very famous, and topoisomerase inhibitors. What are topoisomerases? They are the one which are involved in DNA replication. Yeah, exactly. Okay, so chemotherapy is very advantageous for metastatic diseases, can be curative in some cancers. Curative, that's very good news. In leukemia, lymphoma, can shrink tumors pre-surgery, neoadjuvant, you already know that. Limitation, it is non-specific. Bone marrow cells are also rapidly dividing, so bone marrow is also affected. GI tract, of course, hair follicles, immunosuppression, nausea, hair loss, fatigue, and tumor cells develop resistance over time. Okay, so how chemotherapy works? The patient is administered, then it circulates in the entire body. Chemo attacks fast-growing cancer cells, cell death, and tumor shrinkage. Look at the side effects. It's pretty serious: fatigue, hair loss, skin changes, nausea, loss of appetite, weakened immune system, bladder, kidney problem, bruising and bleeding, peripheral neuropathy, everything, fertility issues, trouble remembering and concentrating. The whole system basically breaks down, because just imagine every cell in that person's body is dying. The brain cells, everything is dying. So everything which is happening in life falls apart. That's why people say that cancer will not kill them, chemotherapy will kill them. Because initially the body is healthy, so they can tolerate chemotherapy. And after some time, almost every person, they gave up, especially people who are very old. Because chemotherapy, if the cancer is not cured and chemotherapy is continuing for a long time, they cannot take it. Either way they will die, but they feel so rotten upon taking chemotherapy that they decide if they have 1 week to live or 2 weeks to live or 1 month to live, they rather live being conscious. Okay, so let's compare surgery, radiotherapy and chemotherapy. So this is obviously local radiotherapy. Also we give to localized tissue. This is systemic. Specificity high, skin cancer, very specific, you can see it easily, right? But it is still under microscope, like we cannot see cancer cells, we cannot do surgery just by eye, it still has to have microscope. And specificity is low because of course the whole body it is circulating, so there is hardly any specificity. Best for localized solid tumors. This is radiotherapy is also local control. Chemotherapy is best for metastatic or blood cancer. Blood is circulating throughout the body, so obviously it is good for. Yes.
Cyclophosphamide being a small molecule, so will it also go to brain and affect neurons, madam, during chemotherapy?
I don't know if it crosses the blood-brain barrier, but if it crosses, it will affect the brain also. But I am sure there is some analog of cyclophosphamide which does not go to the brain. You can make it so that it is not that permeable to brain. But most common drugs for chemotherapy are paclitaxel, vincristine. These guys,
Yeah, these are huge molecules.
these are huge molecules, they won't pass. Yeah. So yeah, that is the advantage and disadvantage of small molecules. Sometimes you want it for glioblastoma and all these things, you want to go there, they go there. That's good because biologics don't cross there. So that is the good part, but you can always make it bulky enough so that it doesn't go there. Now, surgery is not effective for micrometastasis. Micrometastasis means small tumors have formed elsewhere, like really small dots here and there. Okay, and curative potential is very high, especially for early stage cancer. Okay, this is moderate, this is variable. I know of people who were cured by chemotherapy. So I told you about a young lady, 40 years old. So she has mouth cancer. She was just very negligent about her mouth was swelling and she did not take care of it. And then by the time she showed it to the doctor, it had spread to the lymph nodes. So it was very poor prognosis, right? Because once it goes to the lymph nodes, so she was taken to Mumbai, and the most famous doctor in India for this mouth cancer, he did the surgery. So he was super aggressive. He took out the teeth also. He took out the lymph nodes in the whole area. So, but he saved her life. And it has been 4 or 5 years completely cancer free. And that was metastatic cancer. And she's totally fit and she was given chemotherapy. So she has some side effects even today, like, you know, teeth are removed. So she can take limited food and she cannot tolerate too much sound or things like that. She gets tired. So even after 5 years, but you know, when you're 40 years old and it is a question of life and death, he did a very good job in saving her. So, and if it is breast cancer, once the surgery is removed, person is good forever basically in the most cases. So there are so many. We have a student in our department, he had testicular cancer when he was maybe 16, 17 years old. So he tells me if somebody has to have cancer, they have to choose for testicular cancer because it's totally 100% curable. He's very upbeat guy. He's such an upbeat guy that he was himself a kid, right? So when they used to give him chemotherapy, they used to give him chemotherapy with all the other kids who were getting chemotherapy at the same time. And he would keep them so entertained that all the kids were laughing while they were undergoing chemotherapy. So he's a very positive person. So what I'm trying to say that even chemotherapy has side effects. It really cures many cancer. You know, people lose hair, but once they're cancer free, they grow hair. Right? So it's not the end of the world. Okay. So basically you guys already know this thing, I have said it many times, right? Okay, so what people usually do, that even if they do surgery, they combine it with chemotherapy. If they are giving chemotherapy, they will combine it with targeted therapy, double attack, right? If they are giving a hormonal therapy, they will combine it with chemotherapy. They will combine chemotherapy with immunotherapy. So usually we attack, because the goal is this: we don't want to give cancer a chance to develop resistance. So we want to attack, we have to attack it in more than one way, but make sure that the patient does not suffer too much toxicity. Because in an ideal world, you can combine many drugs at once, but then they all have side effects, and the person may not be able to tolerate. Okay, so you have to be very judicious in combining the therapies. Okay, so that's what it is saying. Non-precision therapies can be often combined with targeted therapy, like anti-EGFR, like Herceptin with chemo with immune, and hormonal therapy with chemotherapy. So why combining chemotherapy with other precision therapy is good? Because it overcomes resistance. Before the guy develops resistance, right, you want to kill it completely. Synergistic. Most of the time when you combine them, it's not additive effect, it is synergistic effect. Okay, it reduces tumor burden and broader coverage. Broader coverage means if you give immunotherapy, basically it activates the whole immune system, right? So even if you are giving targeted therapy, you are giving immunotherapy at the same time. So it is taking care of the rest of the body. Okay, so it is broader thing. So this is chemotherapy, radiation therapy, targeted therapy. So depending on the kind of cancer, one has to decide what kind of therapy. So one very common therapy is given even if you don't know the targeted what is the actual thing is wrong. Suppose a patient comes and the disease has been diagnosed at a stage where it is already metastatic and it is rapidly going. Okay, so you don't really have time, especially in an organ like liver, you have to do surgery to do biopsy also. So it's surgery is very dangerous in cancer also, because you are taking out tissue just for biopsy, but the tumor, these cells, they spread around, you don't even know what they are going to do. So in that case, first priority is to stop cancer from growing. So what you do, you don't even have enough time to go for targeted in that case, right? In some cases, biopsy is easier. For liver cancer, it is not that easy, right? Because it is deep inside. So what you do, you give immunotherapy. Immunotherapy will wake up and by the way, we already have this data that immunotherapy will be very good in these kinds of cancer. In these, chemotherapy will be very good. In these, both will be good. So we have some guidelines there. But if you have to give immunotherapy with another systemic therapy, what would you give? Can you tell me when you don't know the target? So immunotherapy is good. It's very, very good with less side effects, right? So immunotherapy is a no-brainer, right? But what else would you give? Chemo is one option. What else? You don't know the target. So think about what is going wrong in cancer. Think about the physiology of cancer, tumor, hypoxia, then what happens? Anti-angiogenesis, that is extremely effective. Before giving chemo, usually most of the patients are given immunotherapy and anti-angiogenic, because if you stop the growth of blood vessels, tumor cells really cannot survive. So you are attacking right at the tumor site, anti-angiogenesis and waking up the immune system. So together they are extremely powerful. Okay? Okay, so this is just many, many different kinds of therapies here. So see, chemotherapy, radiotherapy, surgery, they are combined with many different ones. I'm going to tell you about ADC PROTAC today in details. Okay, so see, immunotherapy itself is of many different kinds. PD-1, PD-L1, they are checkpoint inhibitors. They are cytokine therapies. This is very important. PROTAC. We'll spend quite a bit of time on PROTAC. ADC, antibody drug conjugate. We know antibodies are very good, right? Because they go to the site. So we attach the drug to it. So antibody is going there, killing it, activating the immune system, plus the drug is also delivered at the same time. Okay, this is antibody-directed enzyme product therapy. I have already told you about this. Can you give me any example of antibody-directed enzyme product therapy? So let me remind you, I give a prodrug. Why do I give a prodrug? Because prodrug is a drug which is hidden like this. So we can give it systemically, orally, or by injection. So our whole body has this thing. But this is not going to be effective because this is masked here. But only the tumor cells can remove the mask by the time this drug is at the tumor site, so it will go in the tumor and kill the tumor. So do you remember anything we give it to the tumor cells simultaneously, that they express something so that they can remove that? Because human body doesn't have that gene which can remove that. So it is given in a foreign way. No, you can give it, you can target it using folate receptors, that's for sure. That is for sure. So that is one delivery mechanism, and that will specifically go there. But something will also go to the other parts of the body, right? Huh?
Antibodies.
Yeah, you can give it by antibody and it will go to the tumor site, you are right. But I'm talking, that is a very good way of doing that, just like folate receptor. But if I have a product therapy, right, and we give this product by injection, so it's going through the entire body. But this mask will only be removed by tumor cells, because we have already given something to the tumor cells so that the tumor cells can only remove the mask. Can you tell me how? Suicide gene therapy. Remember, we were giving the TSK gene only to the tumor cells. That's the name. And then they monophosphate this drug, remove the thing, and then it is only effective there. That is what is in this one here. That's what it is. Okay. So the point is there that we have so many tools in our arsenal. We can combine them. Okay. Usually doctors, when they see that the tumor is relatively localized, they are very motivated to attack it in many different ways. Especially it is very important for younger people. There is an age discrimination. Older people cannot really handle a lot of these kind of things. Okay. Okay, so this is just telling you there is a tumor, you can do immunotherapy, chemotherapy, combined therapy, okay, and together they are always more effective. So common combination theory, chemo plus targeted, chemo plus immunotherapy, chemo plus biologics, monoclonal. ADCs are antibody drug conjugate. You are giving the antibody, but you are also attaching a drug to it. So it's like very effective, okay. High response rate combination, delayed resistance, improved survival. The more combinations you give, the chances are it will be more toxic also. Okay, more complex treatment schedules. Not all patients tolerate combination. So one time I was hearing a talk, right? So about combination therapy, and he was talking about something specific. So this is very interesting. So suppose I told you that we are giving two drugs at the same time, two targeted therapies, okay, or one systemic therapy, one targeted therapy. So this is a very common occurrence, that if you give them together at the same time, okay, it will be less effective. But if you give one at this time and second after 24 hours or 48 hours or 12 hours, it will be super effective. Okay, so in some drugs you have to give one so that the system is sensitized, then you give the second. Then you after some time give one and then the second. So not always you give both of them together. So that has to be determined, So that's why the scheduling can be very complex. Okay. Okay, so this is chemotherapy 30%, targeted therapy 80% response. So that's very helpful and less side effects. All right. So we stop here. We have plenty of time. So let's start the next one.